Thank you, and thanks for the invitation to give this talk. I think I sent Andrea a different title, but he made this the title, and so I became interested in, because it's an interesting question that Andrea was asking. So I said, okay, well, I'll try to understand it. And of course, this has at its roots, this question has the general issue of estrogen and cardioprotection. And as you will see, I'm going to talk about how the so-called elite study showed only cardioprotection to the extent of protection changes in the CIMT, but not in the coronary artery calcium. But I think there's a whole lot more to learn about this. To put you into the picture was something you all know, which is that in contradistinction to the life history, let's see if I can, no, I guess I can't. Nope. So in contradistinction to the life history of a woman around the 1900s who died very often due to some acute illness, when you get to the lifespan of somebody who is dying at the year 2000, the chief causes of death are all chronic disease. And in fact, the likelihood that all of us will escape a chronic disease as a cause of our death is pretty slim. We might get run over by a car or something weird, but we're going to die of chronic disease. We need to understand chronic diseases, which include coronary artery disease and stroke. As you can see, the two things that are cancer, is the white line. Breast cancer, in this case, it was women. So some chronic disease is what's going to take us away. We need to pay some attention to this. In short, what I'm going to show you is that since heart disease is the chronic disease that is most likely to take all of us away, but in women particularly, it's underestimated as a cause of death. And we have to do, this is our job, to bring this information to our public, that in the case of estrogen and cardioprotection, it's now been proven that, and accepted, that estrogen is cardioprotective in women who are postmenopausal, who are treated in a timely way, starting around the first year to maybe up to 6 years after menopause starts. They will show evidence that shows they have less accumulation of atherogenesis, and that, of course, leads to atherosclerosis, which, of course, is the cause of death. So this is about how this happens and how much more we know today than we did before. Why are we in this position now? We're in this position where, for example, the use of hormone replacement treatment that could be cardioprotective has become relatively uncommon, where we are teaching our students and our trainees not to give hormones, and where we are in real difficulty with patients who, in fact, are taking all kinds of things to avoid exactly the things that proper treatment estrogen would do. So why are we in this position? We're in this position because of the Women's Health Initiative. How did the Women's Health Initiative get in this position? Well, the Women's Health Initiative was conceived in the 90s at a time when there were not reliable methods of non-invasively testing for the presence of cardiovascular disease. And so, because of this inability to resolve this question, they made a protocol that said, okay, since we have to have cardiac events, we have to include women who are likely to get cardiac events, so then we will have the power to see the difference. So it became, instead of a hormone replacement therapy study, it became a hormone treatment study. You go out to put a newspaper out there, says if you want to be part of a study, come in, and there's no age limit. And so, in order to get enough events in a power analysis, they ended up with a population that was averaging 63 years of age, 10 years longer, 10 years past the time that most of us in the room would be treating people with hormone replacement therapy. This was hormone treatment, not hormone. There was no indication for it. Just come in, we'll give it to you. And so that's how the Women's Health Initiative got into this position. I don't think it was a position that they understood, and certainly they weren't happy with having to have this many older people. But because they did not have non-invasive methods, they had to study more women, and women who would be older and would therefore have more events, because the events was their endpoint. So the Women's Health Initiative then turned up data that said that if you treat older women, if you start giving them hormone treatment, estrogen treatment, you will cause them to have heart disease. And in fact, this is true. We knew this a long time ago because in I think the mid-70s, somebody decided to treat men, gave them 5 milligrams of Premarin. They all had infarcts. They stopped the study. Well, why do we have to do this over? So we knew this, and I suspect that the people who were forced into doing this in the Women's Health Initiative, they knew this too, but they had the money, they had to do the study. Okay? And they published a 35-page paper describing how they did the protocol. You can look it up. It's in something like the American Journal of Epidemiology or whatever. And this was what the nut of the whole thing was about. So in the interim, since the planning of the Women's Health Initiative, we have developed and proven, not I personally, but people like Howard Hodis, Matthew Budoff, these people have developed and proven that there are at least 2 very reliable, precise, accurate methods of doing non-invasive monitoring. And these are to follow the expansion of the distance between the walls of the outer and inner wall of the carotid artery, CIMT, or to look at the aggregation of calcium in degenerating plaque in any vessel. And you do that by putting a dye into the vessel so you can see the vessel, and if you see the degenerating calcium right there, then you can be sure that it's in the vessel and it's degenerating plaque. So that is the coronary artery calcium. And let me go back. So, and generally, when the first studies came out using these techniques, it was common to take a large group of women or men in a clinic and test them for both. So now these were cross-sectional studies, and we kind of got used to the idea that CIMT's thickness went along with coronary artery calcium. But that was a byproduct of the way that the studies were done. they went into the clinic and just did cross-sectional studies. And so it's not surprising when you looked at 70, 80, 60, whatever it is, year-old people, you saw both. So we started to ask, when people started to use these in estrogen, we kind of expected that both would go together. Now we have to understand why should they go together? They're complementary, but they're not contemporaneous. So let's find out what the coronary, the intimal medial thickness actually does. Atherogenesis, the process that underlies plaque formation, is a product of vascular inflammation. Peter Libby, really this was a terrific insight by Libby, and of course inflammation means the accumulation of immunocytes, predominantly in this case macrophages, so monocytes, that are recruited from the circulating blood, then go into the substance of the artery that is injured by something like hypertension or maybe a physical injury, often at a place where there's an intersection, where there's a place of some turbulence, etc., and you set up an inflammation that becomes plaque. The plaque widens the vessel, and if you look in a very specialized way, as Howard Hodis and many other people have now done, you can show that the accumulation of plaque is associated with a thickening of the artery in a very graded way. And this is really terrific. But you didn't hear anything about calcium here. CIMT predicts atherogenesis, but you didn't hear anything about calcium. And atherogenesis leads to atherosclerosis. So how does atherosclerosis come about? Because, of course, that's the real enemy, atherosclerosis. You could walk around with plaque all your life. But now you have to have something that's going to give you an attack. And that is, in fact, plaque, which dies and is calcified. The calcium may not be carried away, or it can be seen by this technique. So what is the role of estrogen in this? And in fact, I won't go into the details, but now people like ourselves have shown that estrogen enables the tethering, blocks the tethering of captured monocytes from being brought down to the endothelium where they can crawl underneath and cause plaque. And this is the first interaction between the circulating monocytes and the vessel. So this is probably a critical action of estrogen in cardioprevention. And what we and others what we showed is that you can use estrogen to change the NCAM neural cell adhesion molecule tether to block its formation and therefore the capture of the cells. So there's a lot of studies that have now, after the initial shock of the Women's Health Initiative, have studied this, including the Women's Health Initiative, and have started to show the Women's Health Initiative itself and some other prospective randomized trials, and some that are not prospective, that are retrospective, but are very compelling to show that, in fact, really estrogen is cardioprotective. So if estrogen is cardioprotective, what are the rules that govern this cardioprotection? And so we and others did a number of studies. I'll show you some of them in a moment. But the idea is that one has to study atherogenesis and then atherosclerosis. You don't have to study them together to see a change. If the WHI people had known how to do this, we would never be in this position, because they would have done menopausal hormone treatment. It would have shown exactly what everybody else had shown. So we have to know about the vessels that are about this contemporaneous changes that protection. And so the first one that really showed this specifically and indubitably is the ELITE trial, which showed changes in CIMT, but did not show coronary artery calcium. Should we be worried about that? The answer is no, because the trial had a median length of 5 years. Had it gone longer, then some of their subjects would have shown changes in CAC, and their controls would have shown less changes. And so it's a matter of not expecting CAC, which comes later, to be seen in a short trial. So just quickly, to just go over these very quickly, the first one was the KEEPS trial, which showed that there was a decrease in risk factors, but didn't show a change in either CIMT or the CAC. The ELITE trial showed a difference in CIMT due to estrogen treatment, hormone treatment, menopausal hormone treatment, but didn't show a difference in coronary artery calcium. And then the WHI continued their studies and didn't do CIMTs for whatever reason, but did coronary artery calcium on patients who were now 7.4 years post-starting, and showed the difference in coronary artery calcium, less. And finally, our own study of postmenopausal women in China, which after 1 to 3 decades, this was published in Gynecologic Endocrinology in 2004, after 1 to 3 decades of hormone treatment, had a clear difference in both. So you see the chronology. That's what I want you to think of. So the delay between the two may show this sequential difference. So what I've told you is that estrogen is cardioprotective, that it's been proven now by the appropriate methodology, and the limits of the CIMT and the coronary artery calcium need to be taken into account when one tries to weigh up the subjects. Finally, I have a list of 5 subjects that one might undertake, but it's not necessary for this talk. We're going to publish a little tiny chapter, and anybody who wants to do this is welcome. Thank you very much.